What are the most common HRT mistakes doctors and also patients do after starting women on HRT? So I have seen with women in menopause staying on progesterone on a continual doses of it, so not going cyclical based,
Yeah.
in order to help with osteoporosis, because we know that progesterone is critical for how we preserve our bones. Sleep, because of like sleep disorders are common when you have no progesterone,
Yeah.
and for
Anxiety.
yeah, exactly, moods, and then lower sex drive. I have seen people stay on progesterone and then also add in some type of ovarian testosterone therapy, because you're not creating estrogen, you're not also creating ovarian testosterone anymore. So you need to be able to replace. And for some women going on it for like libido reasons, they'll find that they only need it for a little bit of time and then they can go off, and then they can,
Hmm.
maybe if they start to see a decrease again, they do a little bit. It's almost like blast and cruise, except for you're not cruising
Yeah.
on the hormone, you're cruising on your body. Um,
So it
and
does it shut down in women? Like, say if a woman wants to
mhm,
supplement with progesterone, sorry, with testosterone,
yeah,
does her body, like a man's, shut down and stop completely producing her own natural testosterone, or?
yeah. So controversial. I actually was down a if you could see this side of my desk, there are papers everywhere because I was down a rabbit hole for most of this week on that exact question. And I can say that it's there. So number one, I can hypothesize, I can theorize, but from a research standpoint, there is just not enough research to
Gotcha.
actually say what is happening, because the research on women and androgens is really, really bleak.
Yeah.
And it's often that co they are using polypharmacy. They're using an estrogen and an androgen. They're using a progesterone and an androgen.
Exactly.
So it's not going to be the same as just somebody utilizing. What I've seen is it depends on the type of drug, right? If you're utilizing an bioidentical testosterone versus a synthetic derivative of a testosterone,
Hmm.
um, because that's going to change and alter how much free testosterone, total testosterone you have in your body, and how your body is binding it with SHBG, or the sex hormone binding globulin. And it's
Gotcha.
going to also change if you're aromatizing with, say, a bioidentical or not with a
Gotcha.
synthetic derivative, right? As women, we have our hypothalamus pituitary ovarian axis, HPO, and we have our hypothalamus pituitary adrenal axis. If somebody is on a hormonal contraceptive agent, they are shutting down their hypothalamus pituitary ovarian axis. That gets shut down. That is, I mean, what you think about in men that have shut down, that is
Yeah.
them getting shut down.
Gotcha.
And that their their hypothalamus pituitary adrenal axis can get displaced in some individuals, meaning that they also will see changes to their adrenal hormone production, like DHEA,
Hmm.
as a result of. But again, the research on this, it is just really all over the place, because there are so many different types of hormonal contraceptive agents that all utilize different forms of hormones. If we think of even just the synthetic progesterone family, as I mentioned, you've got to create those synthetic progesterones. Some are going to be derived from progesterone, and some are going to be derived from testosterone. So they're going to look more like testosterone, like a bastardized testosterone. They are going to look like a progesterone, what you actually should be creating in your body molecule. And so those are going to have different effects on the reproductive hormones of the body.
Gotcha.
So I have seen with the use of androgens in higher levels, I have seen for athletes, profiles of women,
Hmm.
I have seen everything. I have seen low androgen levels, so low testosterone, both free and total, with super low SHBG. I have seen, which means that they are most likely, there's some synthetic androgens in the loop there, and that's why you're seeing this change. But I've also seen some that it's super, super high free test, super, super high total test, and SHBG that is definitely below what you would want to say is optimal for a woman, but not rock bottom. When a
Gotcha.
woman is on a contraceptive agent, conversely, you're going to see that their SHBG level is really, really high, because
Hmm.
estrogen, synthetic estrogen, actually is going to alter that level, even though sex hormone binding globulin, you're going to be more likely, it's got a greater affinity for androgens. You're changing your ovarian androgen production when you're on a hormonal contraceptive because you shut down that axis.
Gotcha. Oh,
So I
wow.
know it's an indirect kind of answer to your question because it is complicated.
Yeah.
Cyclical progesterone, for example, cyclical natural like micronized progesterone should not shut down an axis in an environment that is it's being used for ovarian hormone therapy.
Okay. Okay. That makes sense.
But there's so many different, I mean, there's women, we are amazingly complicated creatures that need so much more research done
Yeah.
because the research is either shit or it's inaccurate.
Yeah, that makes sense. And you know what? I think they can also do all these studies where they're okay, we're going to test this variable, but then there's all the variables that come before it, like you said, like oral contraceptives. Were they on oral
Mm-hmm.
contraceptive?
Yeah.
Did that change, the way their
Yeah.
hormones are working in their body today? And is
Yeah,
that actually really
absolutely.
looked at in this study? And
Yeah,
because it has a huge
absolutely.
impact.
And that was even like a lot of the reasons. So women's hormone replacement therapy, it has been so controversial over the last couple decades where you get these big kind of studies and discussions of it, like the there was this big women's health initiative that was like, HRT is good. And then, no, it's bad. Oh, well, maybe it is
Yeah.
good, but not in everybody and not with all drugs. And I think that's really a beautiful picture to say that ideas not only shift, like science is not perfect. It's a
Yeah.
very biased, often discussion of these drugs, and that women and men alike, we have so many different inner predispositions that are going to influence how we respond to certain therapeutic interventions. Like one of the most incredible things that I see with women is that they are doctors are more likely to prescribe an hormonal contraceptive or a hormonal IUD for heavy bleeding, either in the reproductive prime or in the perimenopausal period. When we know that heavy flow is a result of high, usually prostaglandins and an inflammatory response, and that by utilizing something like an anti-inflammatory, you can actually stop this complex intercycle from happening and decrease an individual's flow by decreasing the amount of inflammation in the body. And so instead of going towards this therapy that is less overwhelming for the reproductive life cycle,
Mm-hmm.
they opt for something like a contraceptive, which blows my mind. I mean, I don't say to people like, oh, everybody go on anti-inflammatories. It's totally safe because it's not, but
No.
used in the right way for a short kind of basis intervention, in addition to working on reasons why somebody might have high inflammatory rates in their body, it can be a really vital therapy. Even something like GLA or gamma linolenic acid,
Mm-hmm.
which is what's either boronge oil is a bioavailable form, evening primrose oil. It is research has shown maybe potentially not as bioavailable as boronge oil, but it works with prostaglandins. And so with women taking that long term, what can happen is a decrease in prostaglandin production at the ovaries, cramping is lower, therefore
Oh, wow.
heavy flow slows down.
Okay.
So something like that, although kind of in I guess us at the margins of research are like, this is so cool. This is such a vital piece of therapy. Research is supporting it. It's not being taken up by the everyday clinician. And I
Mm-hmm.
don't blame the everyday clinician. I don't know any of you guys are in Quebec. I'm in Ontario.
Yeah.
I've got lots of colleagues in the States that are working in clinics. They are so fucking overwhelmed. The medical
Yeah.
system is broken, and it's
Yeah.
not broken at that what doctors are doing. It's broken far deeper than that.
Yeah.
It's broken at how we even perceive hormones, the ideas that have been assigned to what androgen replacement means in a woman. And so I have compassion, but also it's scary to know what certain individuals are being put on, or the implications of them having certain forms of hormonal therapy that's not been appropriate for their physiology.
Yeah, that's a good point.
Yeah.
Wow, that's a lot of information. Thank you for all that.
Oh, you're most welcome. I don't know if you wanted me to maybe touch on any of the questions that some of the
Um, yes. I don't know how quickly you could touch on just on testing for women when they want to do HRT.
yeah.
But depending on how long of an answer it's going to take for you, because I know you might not have a lot of time, but so
Yeah.
I'll let you, yeah.
Yeah. So with testing, it's really important, in my professional opinion, for women to start their journey by tracking.
Yeah.
Track first, test later. Because testing has to be looked at in context. And when a woman's hormones are shifting, right? Like we know perimenopause, it it is a crazy time for women's hormones. Like
Yeah.
puberty is a crazy time. Things are going high and low, and it's going to be specific to the individual. So testing um, should be done in accordance to, when possible, um, where somebody is at in their reproductive monthly cycle, or
Yeah.
bi-monthly or tri-monthly or whatever. And that in tracking, I mean, something like knowing whether or not you ovulate, it, it can be really simple. It can be taking a basal
Temperature.
temperature,
Yeah.
checking for cervical mucus, seeing if your cervix has dropped or changed position, looking for other signs of, say, like if you're, and I typically will say, like, unless there are, obviously there's going to be outlying cases, but typically speaking, track your hormones for 3 months, see what's up.
Mm-hmm.
And
Because
by
it's
doing
not going to
that,
be the same 1 month as it is going to be the
no,
next month or the
absolutely
next month.
not. And
Yeah.
and by that, like tracking for breast pain, looking for, say, skin changes, how much flow. Heavy flow is, I think it's 16 heavy tampons in 24 hours.
Yeah.
That's a lot.
That's a lot.
That is a lot. So knowing kind of what you're watching out for, looking for things even like mood changes, sleep disturbances, agitation, lack of motivation, frustration, all of these, and it doesn't need to be complicated. But doing that to then be able to go like, okay, if you're still ovulating, let's say you're in your reproductive prime,
Mm-hmm.
well, getting lab work to see whether or not on where your progesterone is pretty important, because then we can find out you could be ovulating, making a little bit of progesterone, but not quite enough. And
Yeah.
something like an ovarian hormone therapy with a cyclical progesterone in a dose to just bring up your own creation will do a lot of good. If you're somebody that has an anovulatory period, going and being able to get that lab work done at a point where we can actually see whether or not you are making any progesterone. I mean, I laugh. I look back at, I've got all my lab work for the last like 15 years. And there was a period in my life where I was really, I mean, I was working with Dr. Serrano.
Yeah.
That's how I became who I am today.
He's
But
fantastic.
he is, and I can remember, though I had about lab work done, in the period of time I should have been creating progesterone. And I was at point two, like 9 months in a row.
Oh,
And
wow.
that's not making progesterone, but unfortunately, in the, I guess, the more mainstream medical world, they weren't, when, even though I was like, I'm getting these lab work done at the time I should be creating progesterone, they were like, oh no, you were probably just in follicular. And I'm like, no, I wasn't.
No.
Check my LH and FSH, because those are other two really important markers for women to keep an eye on.
Yeah.
So going back to your question about testing, there are different methods, right? You've got serum, you
Yeah.
have dried urine analysis. I mean, there's hair, there's a bunch of different methods.
Mm-hmm.
People need to use what is going to make sense for their finances. Do not go broke testing for hormones,
Yeah.
because I can tell you that they are still only a snapshot in time of you at that day.
Yeah. Well,
What's going
don't they
on?
also fluctuate during the day? So it depends
They
on like
do,
when
yeah. So, for
exactly you're taking.
example, testosterone is highest in the morning. So, when guys get
Yeah.
lab work done and they're on TRT, or they want to go on TRT and they're going at all different times, I'm like, just do it at the same time. Give yourself data to be created. Also, we can look to other markers for help. I mean, with women, like I mentioned, looking at something like FH and LSH is really, really important because in menopause, we see changes to our FSH and our LH. We see that levels are going up. And if you're getting lab work done and you're now going, okay, well, I'm seeing this increase of my gonadotropin hormone, then that could mean something that's really, really important, especially if you are, say 35 or 38 years old, trying to figure out what's going on. If you're seeing a ratio of really high LH and really low FSH, that can signal something is potentially going on.
Okay.
Especially when we look at that in the kind of the blueprint of what a typical hormonal fluctuation is in the menstrual cycle.
Gotcha.
Um, I still like kind of stand true to like the track, track, because if somebody is on, say, some type of ovarian hormone therapy in perimenopause, the protocol is going to have to change when you should
Yeah.
be in menopause
Yeah.
because of everything I just talked about. We have this homeostasis we need to create in our body. That's just really, really important. And that I think one of the other kind of factors to consider too is in Canada versus the US, we have different access. So some people's physicians will challenge them in Canada when
Mm-hmm.
we are not a pay-per-fee service.
Yeah.
And it is incredibly difficult as a woman to get testing through our government funded healthcare.
Oh
It
yeah.
is
Yeah.
so difficult. And it boggles me because when you look at the cost of how much it actually costs to get, say, something like serum testing done versus putting somebody on a drug for an extended period of time without testing, this is so much more expensive. Like just the cost ratio, like when you look at like Life Labs, Dynacare, that type of thing, it's like a CBC, so a complete blood count.
Yeah.
The cost of that, the blanket cost is like for something
Yeah.
$4. Yet now, if we go to get it ourselves, we either get denied
Mm-hmm.
or it's like 20, I think it's like 28 or something like that. They jack it up.
Yeah.
Um, I have recommended before that Canadians go to the States to get testing done because there are actual private labs that are so much cheaper than in Canada. Canada's private labs, you've got a long way to go still because they're still so expensive. And then something
They're
like, say,
they're they're incredibly expensive. I think the
yeah,
one that my husband and I use is in Montreal, CDL,
yeah,
and I'm lucky I have private
yeah,
insurance with my work, but
yeah,
him and I can do like a blood work, and it'll cost
yeah.
like up to like 1,600 to 2K.
Oh,
Like
yeah.
it's insane.
It's insane. And like I mean, there are like Spectra Cell, Spectra Lab. Um, there are some locations in Canada, but you still need a requisite, but then you can pay out of pocket for it,
Yeah.
or you work with one of their doctors to do it. Um, I'm like, sometimes it's still cheaper just to take a trip across the border if you can.
Yeah.
And use one of the cheaper. I actually have an account with Alta Labs
Okay.
that I am able to get people some testing done at a very reasonable rate. But it still sucks when somebody has insurance and then they can't submit for it because they've gone private, because that is another kind of loophole that we have in Canada.
Yeah.
Um, the Dutch. So where I stand on the Dutch is that it can be a really important clinical tool for some individuals. For others, though, I don't see necessarily the overwhelming value in it
Yeah.
when serum testing can do the job or do the trick, or merely beginning with tracking. So somebody just shells out, $300-400 depending on where they're getting their Dutch from,
Yeah.
and then it's to track a cycle that they could have tracked on their own first and then done serum testing at the right intervals.
That's a good point. Is it as accurate as serum though, or is it?
It's hard to say. There's not enough research.
Okay.
And so there is still this whole world of all other kind of lab testing that third party evaluations are yet to be had at the level to, for me, 100% stand behind them.
Okay.
Serum testing, though, is also something that should only be taken with a grain of salt, right? I think a
Mm-hmm.
lot of value gets put on lab testing, and not symptoms. And that's where I think symptoms can be such a crucial marker, especially when we look at, like, for, say, perimenopausal. Well, the lab values for perimenopausal women, that kind of standard norm, is really tumultuous. We don't know what's going on.
Yeah.
Truly, and I'm being 100% as a researcher, like, there is not enough data to fully indicate, and sometimes ranges get selected off of a hypothesis that might not actually be a good one because of all the
That's a good
different kind
point.
of myths and misconceptions. And we're also seeing changes to the values depending on different labs. Even something like thyroid, for example, we're seeing that the thyroid values are getting pushed all over the place. And often what you see on a standard lab where it gives like, okay, here's your range, that range is standard. It's not optimal. Optimal is different, and optimal is going to look different depending on a whole host of different physiological states.
Okay.
A woman that, let's say, she has a genetic um, deficiency or whatever you want to call it, there's a genetic mechanism that has changed her affinity to actually create sex hormone binding globulin.
Mm-hmm.
Seeing you gotta look at lots of different serum tests and genetic tests to be able to see this, but where I was going with this is that somebody like that, if they didn't know, and then they go in and they get their labs tested and say they don't have any signs of, high androgens, and they don't have any virilization, and they've got a very low body comp, and they are a healthy individual, but they just have super low SHBG. Well, if you look at the range, it's going to say that they are number one, they're hyperandrogenic,
Mm-hmm.
which, but then you look over at the testosterone, and that's just not the case. But
Okay.
clinicians will make decisions based off of sometimes partial knowledge or knowledge that these standard lab tests create for us.
So I think that the takeaway in that is that you just have to know your body. You pay attention to your
Yeah.
body yourself.
Yeah.
You track your symptoms. You track your cycle. You track how you feel,
Mm-hmm.
and you really look at it like,
Yeah.
what am I feeling here?
Well, we can, with research. So I guess as a researcher, it's like when you look at a clinical or a study that's been done in kind of that the medical nebulous or the drug nebulous,
Mm-hmm.
you're getting research that's been done on individuals, no different than you and I. We are individuals. We have all these
Yeah.
inner predispositions. We have all these external factors, and
Yeah.
not just at this point in our life, all those that came before and all those that are going to be coming in our future. So
Mm-hmm.
there's this many different variables going on. And then some type of, even if you control for variables, even if you are, getting individuals that have similarities in, say, their starting levels of androgens, let's just say their testosterone, free testosterone, FSH, LH, SHB are all similar for the starting. And then you're giving them even the same drug. How they are going to respond to that is still going to be influenced by all of these different
Yeah.
inner, outer variables. So, what my takeaway usually is, what I recommend for people is to, just like that study built data through using certain types of methods, what I recommend is that we kind of take the same approach. We can utilize and create data through considering methodology, through applying methodology. Stuff like menstrual tracking. Well, menstrual tracking has been done in numerous studies over the last 30 plus years, and that there are certain variables that have been shown to potentially indicate certain physiological states. And so, as a neophyte researcher that you are, to try to use an unbiased perspective, what I mean by that, don't just go like, oh, I feel fine, I'm not going to write in my diary today. Be like,
Mm-hmm.
no, like, these are my markers I'm looking for, and
Yeah.
I'm going to have a very serious, like, was I actually a bitch yesterday, yes or no, and what's my level on a scale of 1 to 10, and
That's
try
a
to be
great
as
marker.
yeah try to be as objective as you possibly can.
Yeah.
Obviously, there's still going to be bias, but there's still bias in science. Science
That's
is
it.
biased. It's not an unbiased thing because somebody's decided what to test, how to define it. That comes from humans. So utilizing and building data and building it based off of you
That's
as
it.
a human being.
Not
I
what
mean,
somebody else is feeling or what somebody else is
no,
taking or yeah.
exactly. And then we can use the studies to help us analyze, but then we also need to go to professionals. I'm
Yeah.
seeing far too often people trying to analyze others' data without having a full picture
Mm-hmm.
or knowledge about these pre and post kind of things that can influence how somebody responds. I mean, I had this case I got asked by a colleague a couple of weeks ago about some sets of labs, and I was like, okay, I can't, like, I don't know what I'm looking at here. Like, give
That's
me
it.
some background information.
Yeah.
And they gave me a whole bunch of background information. And I'm like, no, the labs still don't make sense off of what you're telling me.
Yeah.
And he's probably going to listen to this. So I'm going to be, or I'll tell him I gave this example later. But I was like, the SHBG was still super high. And so I'm like, are you sure this individual's not on a contraceptive?
That's it. Yeah.
And then it was like, oh shit, actually, she is. Well, that just changes everything because what you thought was, say, non fatty liver is actually the fact that she's on an oral contraceptive. Her
Yeah.
cholesterol that you thought was hyperlipidemia caused from non fatty liver is probably related to the fact that she's on a steroid.
Yeah.
So knowing these things, and I mean, that's just a basic example, but knowing these things can be so critical to how we actually analyze data.
Yeah. That's a very good point.
And I mean, route of entry too. That's another thing that people in the HRT world totally forget. Transdermal application is going to have a different kind of markers that you're going to see elevated or reduced than something like a bioidentical oral. We know that drugs that pass through our liver are going to have different kind of implications for our labs than something that's done sublingual
Okay.
or that's done in a different route of entry. So that route of entry, I always say to people, like, you look at the two things we're looking at. We're looking at drugs. We're looking at a human being. Get your variables down of what you're looking at with the human being. Get your variables down of what you're looking at with the drug.
Yeah.
What can we learn from research about that drug? What's the mechanisms that we should see influenced, and what's with the individual, what should we be seeing with them, and then we can build an analysis. It's actually taking different data sets together and putting a piece of a puzzle together. But if we
Okay.
don't have that, like, what type of drug are you on? What's its route of entry? How is that drug supposed to be absorbed? How is it supposed to be metabolized? How is it supposed to be excreted? You can sometimes draw conclusions that aren't pathological. They're simply by way of whatever it is that they're taking. And sometimes if you buffer them too much, you've now changed how that drug works in the body.
Hmm.
Like, I've seen people that are on birth control try to overcompensate with completely changing their liver function, supercharging their liver because their liver gets depleted and a bunch of different things happen. But then they've now rendered that drug almost inactive. So something and this can happen with even people that are utilizing certain types of, bile support and are, say, taking black market orals.
Mm-hmm. Yeah.
That's problematic. There's a lot going on there that I know we probably don't have time today to get into, but that
Yeah.
there are things that we have to consider. And that's where I think risk management, which is like one of my main areas that I do help athletes and individuals with, is that when we think about how we risk manage a drug, we have to always go back to why somebody is taking that drug, what that drug is supposed to be doing,
Mm-hmm.
looking at how that drug is working in the individual, and then make decisions based off of that.
Gotcha. Awesome. Thank you very much.
You're most welcome. I feel like I'm on like a soapbox today.
Is there anything else that you wanted to mention today, or anything else that you wanted to bring up, or...
I can rapid fire off those questions because I literally actually made myself answer them in one sentence.
Okay.
Um,
Awesome.
so just for any of the viewers or listeners that asked me some questions,
Yeah.
um, one of them was, what are the most common HRT mistakes doctors and also patients do after starting women on HRT? So I
Yes.
indicated
Yes.
a lot of those in this conversation.
Okay.
But one, not recognizing when a woman is in perimenopause and putting her then on the wrong type of drug or the wrong type of treatment, such as, say, going on a hormonal contraceptive for heavy bleeding instead of realizing that that's a sign typically of low progesterone and high estrogen.
Okay.
Also, not recognizing that the body ages as a whole and jacking up levels far higher than they should be in somebody's reproductive timeline. And that can have consequences.
Okay.
That was one of my questions. What levels of E2, progesterone,
You kind of answered that also. I
test,
mean, if you,
menopause do women need to be optimized? So I exactly answered that one. And then what method of HRT, static or cycling, form used? So it was a question just about that. And so again, going back to that reproductive timeline, where are they? What symptoms do they have? And that replacing hormones is not necessarily replacing what that individual wants to have. So like with, androgens, giving a menopausal female high levels of androgens and, make them feel, sexually charged,
mm-hmm.
can still have implications for the individual. So going back and looking at where somebody is just so vital, and that hormones require an intricate balance, and that balance is not just about what you see for estrogen, progesterone, and androgens, but it's also about things like neurotransmitters,
Yeah.
thyroid function, digestion, micronutrients. And so we have to look at the body as that whole unit.
Awesome.
Here's my
And I
rapid
know,
fire.
I know that you're like extremely busy right now. You're
Mm-hmm.
doing your PhD. Thank you very much for taking your time to come on
You're
today
welcome.
and educate us and answer all our questions.
You are most
Um,
welcome.
I know you do coaching, and I know
Mm-hmm.
I'm not sure if you still do coaching. If there's some way that people can reach out to you if they want to.
Yeah. So I do a very, I guess, niche thing at the moment, just because I am trying to finish off my PhD.
Yeah.
I'd like to get that done in this next decade. But that, so I am doing consulting only now. So what that means is that essentially I act as like a person's personalized tutor slash detective of sorts, and that
yeah.
I collect and I get them to gather a ton of data off of whatever their main complaint, problem, whatever it might be. Mm-hmm. And then I will actually compile, sort through, and then give them suggestions on what they can do to move forward. And that sometimes they never talk to me again. Usually I'm like, no, I want to hear from you every now and again, please. But if that's the case, that's cool. Sometimes they need to rebook later on after I give them something to do for, say, 3 months or 2 months or whatever it might be. So I am still doing that.
Okay, awesome. So they can just find you on your website, or they
can
reach out to you that
way?
way?
Go through my website. Social media is really scary for me, so please go through my website and just send me an email, and then I can pass along the information about how to do that.
Okay, and I think you're doing another podcast on I think it's called Full Stop.
Yes, yeah, I actually watched
That's
myself
awesome.
today, so I didn't say it. But so my partner Scott, which I know has been on with Danny before, we are working on episode 2. You guys remind me of you and Danny, of him and I, where we're just like, take 1, take 2, take 3. I think that's what partners do, maybe. But we will be getting out a second episode in time. I'm actually speaking at the Arnold Sports Festival at a private event in 2 weeks. So my attention kind of has gone to that for the next little bit to prepare and get ready for that, while also still working on my PhD. Okay. So, but it will be back out again.
So you don't
promise
sleep.
You there.
You just like.
I do. No, see, and that's the thing is, in the last couple of years, I have prioritized my health. And that it's funny, I was like, I'm just not as productive as I was like 4 years ago. And I was like, no, you idiot, you are healthy. You sleep, you have social relationships, you're not a basket case all the time. Because I used to do like, my full-time research job teaching at the university level and then also doing all this professional work as well, my brain eventually got to a point where it was like not working anymore. And my body eventually got to a point where I saw some things happening that I didn't like, certain markers being off, certain just symptoms and things like that. So I actually took that step back to get healthy. And in doing that, it made me realize I had to scale back. So
Yeah.
I actually sleep like a baby. I have an ovulatory cycle. My thyroid, I've had hypothyroid for years, and I've been able to completely change my dosing in the last about 8 months or so. So it goes to show you that even when you're in this game,
Mm-hmm.
if you're not careful, you can push the stress a little too high and mess yourself up.
Absolutely. Those are all good points. Thank you very much.
You are most welcome. It was my pleasure coming on today too. I was really excited because Danny kept saying that you have to talk to my wife. She's gonna be so much better at this than talking about women's health. So I am
I think it's
more than
just
happy to.
there's just sometimes like women have questions that men just don't think about, or they just,
Absolutely.
you
Well,
know.
it's like when I work with men, I always laugh. It's like I'm a women's health expert of sorts or researcher, whatever you want to call me. I hate the E word. It's just makes me shudder. But that in part my perspective is because I am a woman, and that when you have a menstrual cycle and when you have certain things that go on and with your reproductive hormones, experiencing it is a lot different than just studying it.
Oh yeah.
No different than I don't know what it's like to have, let's say, like unbalanced androgens and estrogens and having like limp dick. Like I can't speak to that because I've read about it. I've heard about it from individuals I've worked with over the years, but I've never experienced it. And I think that is really important in the story of women's health and women's reproductive health, when there is just such a vast like void lacuna of knowledge, and that a lot of the knowledge is filled with these preconceived biases and myths and misconceptions. And part of that's because early on in the game of medicine and medical research, the wrong questions were being asked. The answers that were being given were partial truths because of the stigma and the taboo of menstruation in women, and the misidentification of what hormones and reproductive hormones actually do in our bodies. And I guess closing a takeaway is to say that even something like the menstrual cycle, that people perceive there's a really good grasp of what's going on here, and you can open up a medical textbook and you can see this beautiful graph of like estrogen doing this and progesterone then doing this and LH spiking, and then there's actually been a lot of research showing now that how high estrogen or how high progesterone, pardon me, is showing on these graphs is actually not true. That in reality, when we look at how high progesterone goes when you ovulate, it's like double the height that you see in these graphs. And some people go like, well, that just seems like a misnomer. It doesn't seem like a big deal. It's like, but it is, because this is the graphs then we're utilizing to create things like standards and ranges for lab tests.
Okay.
So something so simple has made a profound impact on how women's health is being perceived, being researched, being diagnosed, and being treated.
All these misconceptions.
Yeah.
Great. I think we'll stop it here for today, because I know your time is like very valuable, and I appreciate again you being here with us.
You are most welcome, and I look forward to hopefully coming back one day and finishing up this
we
talk.
Would absolutely love to have you back anytime. You're welcome anytime.
Perfect.
I'm just gonna get Danny to come back. I don't know if he Dan? Oh, he's there. I'm gonna get him to come back and help us close off.
So how did it go?
She's fantastic.
She's fantastic.
I could listen to her for like hours.
I can't hear her.
I know, it fell down. The microphone. Yeah.
The microphone.
She's got a big smile on her face. I guess it went pretty good.
Yeah.
No, it went well.
A lot of great information today. Like really great information.
Yeah, it was funny because I took those questions like this morning. I sat there and I was looking at the questions that we talked about, and I was like, where do I even start? Like because there's like, I guess once I explain that there's certain context that's required.
Yeah.
Hopefully that helps people to realize that like we got to look at that context first, because I can't just give out like, oh yeah, just use progesterone without knowing that there's so many different forms of it.
Yeah.
I even something like, I mean, talking about like PCOS, my primer for PCOS conversations is probably longer than my recommendations because the PCOS world is just filled with so much mess.
Mm-hmm.
Gotcha. Thanks again for coming on. That was great.
You're welcome.
You
You're
gotta
most
come
welcome.
back.